Thank you so much. I'm Jen Orthmann. I'm here at Penn. I'm an adult neurologist, and I found this disorder in my clinic, and so we have to do, there's a lot to do for it, and I'm thankful that GLIA CTN has included it today so that we can see where we are in the context of all of this other amazing work that has been presented. And so today I'm just going to introduce you to ALSP. We're going to hear about the treatment that has been tried so far, as well as establishing preclinical models, and then hopefully have some time for questions. And as you can see, we had a very enthusiastic response to getting our work group together. We have basic scientists, clinicians, experts in translational work, and experts in microglia and CSF1R. And it's really motivating to go forward to realize how many people are interested in this disorder. And so ALSP is adult onset leukoencephalopathy with axonal spheroids and pigmented glia. And we're going to define it here as an autosomal dominant disorder due to mutations in CSF1R. That designation started about 11 years ago now, where prior to this was a diagnosis at autopsy or on pathology, shown here with the classic signs of myelin loss, axonal spheroids, some macrophages, but also loss of microglia, bizarre-looking astrocytes, maybe not as bizarre as the ones we just saw, but bizarre all the same. And it sort of brought together these three different pathological descriptions, POL-D, HDLS, and ALSP shown here, and became the first microgliopathy that was inherited. And so we know that most of the patients, certainly when they have presenting signs and symptoms, have a leukoencephalopathy with one example shown here, probably end stage at this point. And what can also be found on MRI, but not in all patients as far as we know, are areas of chronic diffusion restriction, and on head CT you could see areas of calcification. Individuals present in the 4th or 5th decade of life, typically, although we don't really know the full range of onset of presentation. And it is clinically heterogeneous. It can present with a motor phenotype, extrapyramidal symptoms, seizures, and neurobehavioral phenotype. So in the adult world, that means you can end up in the MS clinic, the dementia clinic, or the Parkinson's clinic. And so it can even be variable within the family, and we think with possibly incomplete penetrance. Just as we were discussing in our work group, we don't actually know the full range of how this will present. It can be rapidly progressive. And the previous description of this was that people typically died 4 to 6 years after diagnosis, and that may be the end stage version. We don't know if that's true for everyone. So I think this is at least a 2-compartment disorder. I'm showing here the blood versus the brain. And that's because in the blood, you have innate immune cells as well as adaptive immune cells. And in the brain, you have microglia, which are the innate immune cells of the brain. They arise in the blood and the brain from different sources. Microglia come from the yolk sac during the embryonic period, and they self-renew over life. And the innate cells in the blood that circulate come from the bone marrow and are renewed from the bone marrow. But these are, the monocyte lineage are the ones that express CSF1R. And CSF1R canonically, activation of CSF1R canonically activates pathways for proliferation and survival of these cells. But in the brain, as you have heard in many other presentations, we're also dealing with a few other cell types. We've got the oligoprecursors, oligodendrocytes, myelinating axons, astrocytes, and what happens in the brains of people with ALSP. So we don't know the order of things. We know in the most affected areas that there's loss of microglia, that there's loss of oligodendrocytes and myelin, that you develop axonal spheroids, that astrocytes become reactive. And it's not really clear that the blood-brain barrier breaks down, but there might be an invasion of immune cells, particularly in those areas of diffusion restriction in the brain, although that has yet to be defined. And unlike in diseases that I'm more familiar with, like MS, it's not an invasion of B and T cells, but perhaps it's macrophages that are causing all sorts of problems. So here we're going to talk about the challenges and successes we have so far for ALSP. And one of the major successes is the Sisters Hope Foundation, founded by Heidi Edwards, who's here. She can wave, but so this is a new foundation to support this community worldwide, and Heidi has done an incredible job of making contact with industry partners as well as patients and families throughout the world, and is working to establish a patient-driven registry. We know from many of the experts that are involved in our work group, as well as groups throughout the world, that the mutations tend to be in the tyrosine kinase domain, which should disrupt signaling. But how this links with microglia survival, proliferation, dysfunction, and the rest of the damage that happens in the brain is entirely unknown. However, we do have several preclinical models that Josh Bonkowsky is going to tell us about to see if they can help us answer some of the questions about it. And another thing that we discussed that is not clear is whether autosomal dominant CSF1R mutations having that predicts the disease course on its own, or whether it's a susceptibility locus. And you need some other hit, like an environmental trigger or a genetic modifier, so those are some of the examples, to make this adult onset. So to answer some of these questions, we need a natural history study. And there's one ongoing that's supported by Vigil that will be limited, but is an incredible start for our community to have this going already. And I'm very grateful to GLIA CTN for funding my pilot to also develop a natural history study that should be ongoing and collaborative, as well as develop peripheral biomarkers, or really characterize the peripheral blood mononuclear cells in this disorder. And one of the other things we discussed, because their CSF1R and microglia are kind of a hot topic right now, that with many emerging therapies as potential for this disorder, that we really need an industry advisory council to help navigate multiple potential treatments for this rare disorder. So some other successes is that we're going to have an ICD-10 code for ALSP, so that's cool. Thank you, Josh. Again, as we discussed, the population targeted in this session is adults with autosomal dominant CSF1R pathogenic mutations, defined by genetic testing as pathogenic. But it's actually a confusing nomenclature for this disorder because, as you will see, because I kept the original slide sent to me, we're all calling it something different. And if we call it CSF1R-related leukoencephalopathy, are we including Bandos in that designation? These are sort of unresolved things, but also very rare. In the adult world, as I mentioned, you might show up in any number of specialty clinics, and I can tell you that genetic testing is not universally available. And I think what would be most likely to be available is panel testing, and even looking on the clinically available genetic panels that could be sent, CSF1R is not on all of the leukodystrophy, dementia, and Parkinsonism panels that could be sent from different companies. So it's something that through advocacy, hopefully we can do, but perhaps whole exome and whole genome are the better way to go. And then a major unmet need for the community is that we have no disease-specific management and treatment guidelines for symptomatic care, but people at many centers throughout the world have experience treating this disorder, so we need to get together and at least provide a framework to go from. And so we don't have any approved disease-modifying therapies, but because bone marrow transplantation has been tried, Dr. Lund will be telling us some about his experience and what we think it might be helpful for. And so as you can see on our heat map, we have a lot of red and orange. So really, you know, this is my own personal experience the first time of making a heat map. So a learning experience and kind of seeing in context for the other disorders and how much time and effort and the community effort and collaboration that you put in. I hope that next time that we present, we'll have changed some of these colors. Okay, so with that, I'll go to Dr. Lund.
All right, thank you. So given the rarity of this disease and the use of transplantation as an intervention, I'm just going to talk about the clinical scenarios, 2 slides for each patient, and then let you draw your own conclusions. So transplant, so this is one of our earlier transplants, a 44-year-old female presenting with memory problems, disinhibition, early onset dementia. Exam shows some intermittent tongue and lip movements resembling tics. Her mutation is given. The MRI showed confluent frontal predominant white matter T2 hyperdensities, and she had a history of DVTs and was het for factor V Leiden and other clotting genes. Her transplant was a 12 out of 12 unrelated marrow donor. Her transplant-related morbidity mortality was mild GI-GVH, some cystitis. She went to a transitional care unit for aggressive rehab and nutrition. She's a patient where upon receiving GCSF, which is granulocyte colony stimulating factor, she would get very agitated. And at that time, we were wondering if that had something to do with her disease, which is a problem in CSF1R. Typically, GCSF binds to CSF3R. It's a different receptor, but where I was wondering if there was some overlap. But she's the only person we noted this for. 27 months, she had, after transplant, worsening cognitive deficits without motor sensory problems. Her score was 1138 on the STMS. Radiologic assessment showed stabilization of her MRI score, but white matter subscores with incremental worsening of atrophy subscores. And this is true of most all the patients. There were some improvements in behavior. She made good recovery, PT-OT, and she was said to have good quality of life on follow-up. And I tried to pull some of the MRIs with the salient photos in some of these patients. So you can see the pre-transplant ones on top, and then 3 years post-transplant on the bottom, indicating some interval progression and volume loss, but not at every level. Transplant 2, 46-year-old female, rapidly progressive gait deterioration over 4 months. She lost her job. Mutation is noted. Her exam showed hyperreflexia, Parkinsonism, gait impairment. Neuropsych eval shows impairment of visually mediated processing, executive functioning, cognitive speed, nonverbal alerting, psychomotor speed. Her transplant was a matched sibling donor. Her neuropsych eval at 4 months post-transplant showed declines in some aspects of attention, function, processing speed, with some improvements in verbally mediated tasks, including naming and fluency. At 9 months, this is more or less her neurologic exam was unchanged from pre-transplant, and she successfully resumed her role managing the family's finances. At 2 years post-transplant, she was noted to be walking 1 to 2 miles a day, dressing herself and making breakfast. I found her MRIs as well from the pre-transplant and the 2-year post-transplant MRIs. Overall, she seemed to be one of the better responding of our patients with minimal progression noted here. Third transplant's 44-year-old female, progressive personality changes. She lost her job. And this is also associated with memory decline. She perseverated on things, spelling difficulties, falls. She had an MRI at one point. Her mutation is noted, also noted to be losing objects, having difficulty clothing herself. She scored 27 out of 38 on the STMS. She's a matched SIB donor. Our transplant morbidity, mortality was GVHD of the gut, acute kidney problems, strep mitis of the blood. She then had an arrest, pulseless electrical activity. She's resuscitated and extubated, but quickly deteriorated from a neurologic standpoint. 81 days post-transplant, her MRI score was 25. She did not have any evidence of stroke or severe hypoxic injury, but given her substantial neurologic deterioration, family decided to transition her to comfort care, and she died post-transplant day 88. So clearly unsuccessful here. Fourth transplant was a 41-year-old female, 1 to 2 years of lower leg weakness, some memory problems, losing track of conversations. During my interview, his wife was filling in most of the questions and gaps in his memory. He also had 1 to 2 years of depression, anxiety. He was easily losing his temper. You can see there are a lot of common themes here in the presentations of these patients. He had T2 signal changes on MRI in the frontal temporal lobe. His CSF1R mutation as noted here. And his transplant was an 8 of 8 unrelated donor, 100% engrafted. His complications included Pseudomonas pneumonia, Burkholderia, sinusitis, some weight loss, actually requiring a G-tube, which is not terribly common in adults. He also possibly had idiopathic pneumonia syndrome, which he's gotten through. But unfortunately, he's had pretty severe progressive dementia. He's very weak but gaining mobility, but does live in a care facility and receives almost full-time cares. I was able to get his MRIs pre-transplant above, 10 months post as below. And again, you can see evidence of some progression and a lot of volume loss in his MRI as well. Though what I've learned from some of these patients is that their MRIs don't necessarily predict where they're losing and gaining ground in terms of function. So they're kind of all over the place. And so that's, I think, the last slide on this patient cohort. And so the conclusions are transplant does something to this disease, but I have no idea what it's doing to this disease. The risk of transplant in this population is different than the risk of boys with ALD, and that's because these are adult patients with a lot more life exposure. We can go into what those risk factors look like. And also mobility. Having poor mobility is clearly a risk factor after transplant when you're an adult for a variety of reasons. If you're in a wheelchair going into transplant, your outcome is not as good as if you have full mobility. Progression after transplant can be terrible and often requires full-time and often permanent care. And when you're a little kid, it's not so bad because you have your parents around, but when you're an adult, you need to have somebody around to take care of you, and sometimes it's a wife or sometimes it's a parent still, but you're taking care of this patient then probably for the rest of his or her life. So it's a big decision, and if it doesn't go well, it can be awful. Transplant performed too late is problematic, and so now I'm of the opinion that we need to be doing these transplants earlier because we're going to see better outcomes on all aspects of the disease. And now we'll hear from Josh.
Thanks, Troy. Thanks for the chance to talk. I have two caveats to announce. The first is that the ICD-10 code is not yet approved, so we don't know for sure that's going to happen, but there is still an open comment period for, we've asked for about 10 codes, ICD-10 codes to be approved, and so if you'd like to, family organizations, please get your vote into the CDC, and you can contact me for instructions on how to do that. So that's caveat number one. Caveat number two is if I say anything incorrectly or overlook anyone's work, it's through either incompetence or ignorance, so I apologize in advance. So I'm going to talk today about models for CRL or CSF1-related leukoencephalopathy. I'm Josh Bonkowsky. So just some disclosures, nothing related to what I'm talking about today. And so what we're talking about is a bunch of different names, as Jennifer mentioned, and really we're focusing on modeling the leukoencephalopathy related to CSF1R-related autosomal dominant mutations. So if you haven't read this book to your children, I highly recommend it. It's about a fish stealing a hat, and so that's the concept of like a hat. What is a hat? So this, if you don't read French or can't speak it, which I can't, this says this is not a hat, and so, but it is a hat, right? So it's a picture of a hat. So when we think about models, different kinds of models have different elements of reality. And so as we think about using models, we need to think about does the model that we use capture an element of the disease or the reality that we want to, that's important for the process. And so I think the next few slides I'll be kind of talking about general concepts in how we use models. So really there's several goals of a model. One is that it helps us gain insight into disease pathophysiology. So as you've heard with CRL or ALSP, we have understandings of some of the pathology, but really what's kind of driving the pathophysiology is poorly understood and is limiting our ability to treat individuals. Another helpful thing with a model is that you can look at new disease variants. So something we're running into in some of the other fields is that when a new genetic variant is identified, is it a disease cause or is it benign? And so that's something that we'd like to be able to do with a model. And then finally, really kind of an ultimate goal is how do we take care of people? How do we take care of patients? And so can we use the model to help identify or screen for therapeutics? And that'd be also a very helpful thing in a model. So if you think about the pipeline to a drug, it tends to be very long and very expensive, and so it can easily go on for more than a decade. As we know from past examples, there's often places where the pipeline fails, and so you don't it breaks apart. And so really, how can you increase the throughput of a pipeline, and how can you improve the chances of success? And that's something that we really hope that an ideal model will do. So what do you need to have a successful model? So the first thing is you have to understand the disease well enough to know what you're looking at. So for example, if you have the wrong genetic mutation or you have the wrong gene, like that's not a good model. So like a problem in the, so I don't want to, but a problem in the multiple sclerosis field is it's been difficult to have a good animal model. And so these kind of made up models have been difficult for modeling the disease well. A second aspect is that the disease in humans has to be well enough understood that you know what you're looking for in your model, and so you have to know what's going on clinically. So, for example, what are there motor phenotypes? Are there neurocognitive phenotypes? You have to understand the molecular phenotypes because you want your model. You need some sort of molecular readout. So, for example, are you looking at what happens to signaling the CSF1R cascade? What are changes in protein or RNA levels, and you really need that from the patient so that you can say, oh yeah, my animal model or my cellular model captures these same elements. And then you also have to know what's kind of like a primary effect versus a secondary effect. So for example, if you see someone who can't walk very well, is it because you might say, oh, the phenotype's because they have hurt their thumb, but maybe it's because they're missing a leg, right? So you have to know what's really driving the phenotype of disease and what's kind of a bystander effect versus truly driving disease pathophysiology. In general, for one limitation that we've seen is that often mice seem to be very resistant to our attempts to use them for modeling, and so so sometimes we're putting in several mutations in one mouse to get a disease phenotype. And that always raises questions about validity. Really, you're hoping that with one gene, the same human disease variant, that you get the same kind of phenotype for measuring. And that's not always the case, but that would be kind of an ideal situation. And then you want to make sure that your model recapitulates disease aspects. So are you able to see some sort of molecular signatures that are the same as in the human disease? Are there neurologic or physical changes in your model? So for example, if the humans develop spasticity, does your animal model have some sort of signature for spasticity or seizures, for example? Are there changes in function or behavior that you can measure? So for example, with a mouse, can you do something with a rotorod that kind of corresponds to human loss of ambulation? And are there changes either on anatomy or on the CNS pathophysiology that you also see in your animal model? So there's various different kinds of models, and so I've tried to create this kind of artificial scoring system. And so, for example, in silico or big data approaches, they're relatively easy to do. The cost is low because you're kind of data mining or playing around in the computer. The throughput's super high. On the other hand, the questions are can you take something that you discover in silico and translate it to humans? You probably need to do some other validation to make sure that's true. And the same thing for translatability. You're not going to take something you find in silico or just from prediction and go straight to a clinical trial. Similarly, in vitro, so cellular models, they're relatively easy. The cost is lower. The throughput is higher. But the same problems with kind of going into humans. You're going to want some intermediate steps before you take into humans. Cell-based models, so things like organoids, the ease and the cost and throughput's a little bit lower, but then hopefully the translatability is higher. Then finally, animal models, we'd like to believe that they are more difficult. There's higher cost. It's more difficult to make the model. But in the end, we hope that from an animal model, for particularly mouse, or if you're testing something in primates, that you can go right into a clinical trial. So then if we look at animal models, kind of same thing here. There's a wide range of different animal models, and they all have pros and cons. So there are still, there are invertebrate models, so for example, Drosophila. Lots of people are using Drosophila for screening. Again, very easy, relatively easy to use, very low cost. Generation time is short, so you can crank through experiments. But then, of course, people are well, it's a fruit fly. Are you going to use that for your clinical trial? So that you're going to have some sort of mammalian step. Zebrafish, relatively, they're not as easy as Drosophila. The cost is kind of medium. Generation time is not that fast unless you're doing something kind of in the earliest stages of development. And the validity and translatability is better than invertebrates, but most regulatory agencies and stuff want some sort of a mammalian validation before you go into a clinical trial. I'll talk, maybe I'll just mention now that some ways around that are that if you find something in zebrafish, you can then test it in like an organoid model or some sort of mammalian model to prove some sort of efficacy in a human-based system. And the second thing is you can also, if you find something again in zebrafish, if you show absence of toxicity just in a wild-type mouse model, again, that's something that the FDA is looking favorably on. The mouse model has been kind of the standard in the field for many, probably decades now. As we know, ease is kind of medium, cost is higher, generation time is also slower. Throughput, you can't really use mice for screening. It's very difficult to do so. But then there's kind of it's been a gold standard for moving into clinical trials. But as we've all experienced, mice are like it's like a super powerful animal. Like they are resistant to everything we throw at them and seem not to develop much disease. As we've also heard, sometimes people move into rat and like get success from the rat model. So for example, the Alexander disease model seemed that's pretty cool that the Alexander disease rat model had a great phenotype, but of course we're not hearing about the times when the rats failed. So is it just kind of an ascertainment bias where we're not hearing about the examples of the rat model failing? Primates, you can't really do screening or development in primates, but they're often a step before you go into a human trial. So just to point out that if you look across species, that really you want to make sure that the gene that you're studying or the processes that you're studying are conserved genetically in the model system you're using. And so as we mentioned, each animal model system has different pros and cons. And so I don't know if I have a laser pointer or something, but the middle group of genes of the 10,000 genes, those genes are shared across species. So obviously you want to make sure that if you're doing something in mouse or zebrafish, that it's in that middle group that's also shared with a human for that disease, whereas there's some certain genes that are much more divergent, and so that'd be a bad choice to try and create a model and a divergent gene that's too far apart kind of evolutionarily to make sense. So there are, although there's big advantages to doing large data or cellular-based screening, there are also major advantages to modeling in whole animals. So drugs don't work in isolation, and so understanding a drug's effect not just, for example, on the brain or the white matter, but understanding how, what does it do to the liver, what does it do to limb growth, that's really a power of a whole animal system. Some of those things like zebrafish or invertebrates do have rapid development, and so you can do things in a relatively short time period, in the order of weeks, to look for phenotypes. These animal models have lots of genetic tools. You can do lots of clever things with manipulation to understand pathways. There's really cool imaging tools for all these animals. And then you can do, for some of these models, you can do relatively high throughput screening. Even if you don't get a drug that's going to provide a cure, it can give you insight into pathways that then could lead to a treatment. So if you think about, this is a study about 5 or 10 years ago, looking at the new drug categories that have been discovered over the past decades, a majority of them have come from phenotype-based screening, so really suggesting that this is a good way to look for new drugs. And this is just to kind of highlight that these automated screening platforms do exist. This is a zebrafish high-throughput screening platform, so it's basically a computer-based computer tracking system. You put the zebrafish into a tray the size of basically an iPhone, and the computer can track different elements of motor movement, or they can also track other aspects of like fluorescence or something like that. So you can do relatively high-throughput screening for like a large drug screen in things like zebrafish or Drosophila. So just the caveats for any model is that each model requires validation. So just because you created the same mutation in your animal model of choice doesn't mean that it's valid. You need to do something to show that it has the same kind of signatures molecularly, or that you have some sort of like genetic rescue with the human disease gene. As we've proven again and again, some diseases don't work very well in certain models. So for example, the ALD mice again seem quite healthy. We tried to create an MLD model in zebrafish, and when, those zebrafish are great, so no problems. If you're trying to look at an age-related phenotype, that also impacts your model. So for example, much of the advantage of zebrafish is that they have fast development early on, but then as they get bigger, then you have to keep them in bigger tanks. And so looking at something that's chronic neurodegeneration in a zebrafish, you lose the power of working in that system. And then just, science is hard, things don't work, it takes time, so all the standard caveats. So if we look at CRL, there's lots of different features that we can choose for modeling. So really you should be thinking about trying to create a human variant in the CSF1R gene. There's lots of different elements of the CNS neuropathology that you could look at, so ranging from effects on the white matter, loss of neurons and axons, the abnormal astrocytes, the microglia phenotype, the astrogliosis. There's a leaky blood-brain phenotype that's been reported, so those are all like things that you could look for in your model. With the neurologic features, if your animal has behavior you can screen for, you can look at those elements of like motor function. There are other systems affected by CSF1R related mutations, and so you'd like to see is there also bone involvement? Is there involvement of the optic nerves? These are all things in the model that you could look for. So there's also molecular signatures, and does your model have increased GFAP expression? Our favorite marker, neurofilament light, is there increased neurofilament light expression? There's a pro-inflammatory state in the CRLs, and so do you see that in your model? Is there microglial loss? Are there exchanges in the RNA and protein patterns that kind of model the human disease? So really, just to get right down to it, there's really only kind of two models that I think kind of fit the criteria that we've talked about. So in the mouse, there's been a wide range of different CSF1R mutations made. So lots of, several like knockout CSF1R knockouts. Really, I think this paper in 2022 was the one that did the best job of trying to recreate a CRL model. It's a human gene variant. Disappointingly, they did get, on the good side, they got microglia depletion, but basically everything else about that mouse was good. The mice are fine, once again. That's in the heterozygous state. The homozygous mice had a phenotype and did die, but that doesn't really recapitulate the human disease, which is autosomal dominant. So the advantage of the mouse is that you have a variant that has loss of microglia, but not much else that you can use for the disease. So it's the mice, again, are quite healthy. This same year, the group, Berdowski et al., also made a human disease gene mutation in zebrafish. They do see microglia depletion. They see abnormal astrocytes and loss of myelin. They also report abnormal behavior, but that abnormal behavior is only seen in the homozygotes. So again, in terms of a screening tool, which is really like one of the major powers of zebrafish, it's not that great. So these are some of the images from the two papers, the mouse on the left and the zebrafish data on the right. So on the left is the microglial loss in the mouse model. So you can see there is significant loss of microglia, so that's great. So that suggests that the same pathways are affected in the mutant. But so hopefully there's the same kind of molecular signatures in the mouse model. The zebrafish also has loss of microglia. They looked both at the heterozygotes and homozygotes. And so that's shown in the panels labeled E and G, the loss of microglia. On the right, they also do show loss of oligodendrocytes. In the right-hand bottom panel shows the motor behavior. And the motor behavior in the heterozygotes is not affected, where it is affected in the homozygotes, but again, that's not really recapitulating the human disease phenotype. So there are, so you're excited in one way, like, oh, great, zebrafish. There's still problems with using zebrafish because it's in a, fish non-mammalian system, and so there's both, there's NIH regulatory agency kind of thoughts about, can you take something in zebrafish and take it into clinical trials? There still needs to be a mammalian or human-based cell step to kind of make sure that what you have has efficacy in a mammalian system, and that you can figure out dosing, because zebrafish dosing is kind of made up. So those are some of the caveats with zebrafish. So basically, I mean, no surprise, as we've heard, modeling leukodystrophies is no walk in the park. Any model you choose has various pros and cons, and you're just trying to find the best model to fit the question that you're asking. With CRL, there's very specific things that we should be looking for, but our current CRL models are not that great. It looks like with the mouse that there is a microglial phenotype, and presumably some of the biochemical and molecular features are conserved. The zebrafish model seems to have a stronger phenotype, but because it doesn't have a motor phenotype, makes it less useful for screening. So I think it has the best phenocopy match, but I think there's opportunities to make better models for sure. And that ends what I was going to talk about. Jennifer, I think you had a couple things to say.
I just wanted to say some of us met this morning to help participate in the first 5K for Sisters Hope Foundation. This is here on Penn's campus. And it's time for questions.
Josh, I had a question for you. So any idea why the zebrafish seems to be a better phenocopy for the human disease as opposed to the mouse? Usually would think it the other way around. Is it that, maybe is the gene not duplicated in zebrafish, or any ideas or thoughts on that?
So I think we've tried to make about 6 different zebrafish leukodystrophy disease models, and our hit rate's been about 40 to 50%. Sometimes they work well and have a good phenotype and good phenocopy, and other times they don't. It doesn't seem to be related to some easy thing like the duplication of the zebrafish genome, or so it seems stochastic or something that I don't understand. I don't think anyone has a great idea why that's the case.
We do have people on the Zoom watching, and someone had a question or a comment. Dr. Priddens in University of Edinburgh. She wanted to say that she was involved in the production of the CSF1R E361K mouse model with David Hume, and it doesn't develop ALSP, but does have reduced microglia like the patients. And most of her research has involved CSF1R rat models, and so she's hoping, because rat macrophages are more like human than mouse, she's going to create an ALSP model in the rats.
Yeah, and I think it would certainly go along with problems we've had in modeling sort of innate immunity in other leukodystrophies to have mice not replicate the phenotype, right?
Nice talk, Troy. Question, as you pointed out, transplants are not well tolerated once disease is too advanced, and we've gone through all these discussions in ALD. What's the guidance now for inclusion and exclusion of patients? And do you have a sense of how to guide family members who are asymptomatic and show no MRI abnormalities?
Yes, that's a spot-on question. I think some of it has to come out of this work group on what we're going to do. It's always easy to look at the extremes. So anyone without MRI abnormalities or exam findings, neuropsychological evaluation, we don't transplant. Onset dementia, probably wouldn't transplant that patient anymore. Anyone with an EDSS score of 6.5 or higher, the outcomes are going to be, the mortality is going to be much higher, because we've learned that from the adults with ALD and AMN. And then everything else is somewhat in the middle. And so if you show a decline in neurocognition, I think that might be a time to start thinking about transplant, even with very mild MRI abnormalities. And as you know, none of these patients enhance with gadolinium. At least I've never seen enhancement on their MRIs. And so That's why I think earlier is better, but again, we don't do it prophylactically, let's say, because the timing is still wide open. Do you transplant somebody when they're 25, when their mom died at age 45? It seems a little extreme, but I guess close vigilance with yearly follow-up is what we're doing, and neurocognitive testing every year to look for that first sign of decline, which anecdotally, it seems like it's word hunting. You know, that's when I'm talking with the patient. It seems like that's one of the very early signs, but I don't have data for that.
I had a question or comment/question. Just from walking up to the front before the talk started, it sounds like there's now like multiple centers that have had some experience with transplant, and just with now there's kind of like a cohort of patients that we've all kind of seen. So Jennifer, I don't know if you have any comments about kind of like the database and what your timeline is for that and what your plans are.
Well, thank you for asking. Hoping to get some of this information collected as soon as possible. For the pilot grant, as many people that are willing to, I will reach out, and please reach out to us and join our work group so that we can collect the data as best as we can and make it easiest for families to also contribute to that data set is my goal. So ongoing.
Dr. Van Achten?
In Amsterdam, we have also transplanted a series of patients, and we tend to use the criteria that we also use for metachromatic leukodystrophy. So typically the first patient, they are big families. So like they have 6 children and 3 have ALSP. The first is too late, and then we start monitoring the other siblings, the affected, genetically affected siblings. And what's also helpful is monitoring by neurofilament light, because typically when you see the first lesions on MRI appear, also neurofilament light starts to rise. And we fully agree that it's sort of, in our experience, if the disease is already rather progressive, that the transplant makes it worse and patients die. So we are refraining from patients that are really progressive, transplanting patients with really disease progression, and try to be really early in the disease course with the first, actually we mostly go by MRI, first MRI abnormalities and a neurofilament light that's going up. And still, as I was talking, speaking in the break to each other, our outcomes are not great. We have a relatively high mortality, much higher than we see in ALD patients, and also higher than we see in MLD patients.
I would just caution that the intrafamilial heterogeneity is much higher with C1R than MLD.
Yeah.
Yeah, I'm not talking about that. We are just, when there's an adult with ALSP, we test the other siblings and start monitoring. So we are not relying on anything within siblings.
Right. There's one more comment from the chat, which we're going to read aloud. Thank you.
So this comes again for Dr. Pridens. She said that she also wants to apply for funding to sequence patients and non-affected family members, and she'll be in touch with the ALSP work group very soon.
Yeah, and that goes, I think, for anybody who's virtual for all these sessions, is that I think these work groups are still in formation, and very often will welcome members as we sort of coalesce around these common goals. So thank you very much to our speakers. It was really a lovely talk, and a disease, I think, where there'll be a lot of movement in the coming years.